Welcome back to EMS Abounds. I'm outside today, as you can tell. I spend enough time inside that I like to be outside whenever I can. That includes filming, so please forgive the sunglasses, otherwise I'd be blind. This video is introducing a new playlist over the next couple of weeks on the cardiovascular system. Today we're going to talk about anatomy and physiology of the heart and the vessels. So anatomy is the study of the structure, and physiology is the study of the function. So once we do a little review on that, next week's video we'll start into pathophysiology, or dysfunction of that physiological environment. We'll talk about CHF, we'll talk about tachycardias and bradycardias, we'll talk about electrolyte disturbances and imbalances, we'll talk about trauma. Okay. So again, today's an introduction to this. If you're already an EMT or an AEMT or hopefully a paramedic, you certainly should know this, but it's a good review so when we start talking about things in the next few weeks, we're all on the same page. Plus, sometimes, we haven't looked at our books in months or years, so it's always good to have an understanding of how this works. I also put things into terminology that is easy for you to remember at 2 in the morning. That's the way I look at it. So when we think of the cardiovascular system, the first thing we've got to think about is the pump, the heart. The cardiovascular system is, in effect, a pump, a set of pipes, and a fluid. So I remember back in '85 when I was sitting in the Kingston Fire Department classroom learning my cardiac A&P with my EMT class, that I was looking at books, I was looking at notes of the people beside me, and people were making these great drawings. I am not an artiste. If you've ever sat in my class, you know this. So I thought, how do I come up with a drawing that is functionally accurate and something that I can picture at 2 in the morning and keep straight in my mind? So what I came up with is this. It's basically a square. Our heart is not square, and it also doesn't sit straight onto you. If this is the heart, it actually sits a little bit turned to the left and angled out just a little bit, just to the left of center behind your breastbone or sternum. So when I draw this square, we're kind of looking at it at an angle, basically from V5, if you've ever done an EKG. It's not artistically correct, it may not be to scale, but it is functionally an accurate picture. Now, we have one heart, which is divided into 4 chambers. We have an upper half and a lower half. We also have a left half and a right half. And when you're thinking left and right, remember it's my left and my right as you're looking at me, not your left and right. So my left, my right. Now, the top 2 are called atrium. So this is the right atrium, this is the left atrium. Atria, atrium. Kind of like geese and goose, or goose and geese. Okay. The bottom are called ventricles. Right ventricle, left ventricle. The job of the upper half of the heart is to pump blood to the bottom half. The bottom half's job is to pump blood out to parts of the body. So I remember when I was sitting in that EMT class, our instructor, Dick Booth, had this just like OCD thing about us being able to trace a drop of blood through the cardiovascular system. And I'm glad he did, because it certainly made it easier for me. Now, if this is my drop of blood, and it's here in my brain, or it's down here on my big toe, it's got to get into the heart. So we have veins leading back to the heart. The main one that leads back to the heart is called the vena cava. And it puts blood into your right atrium, which then pumps blood into your right ventricle. Okay. So there's my drop of blood. You have to have a way to get blood from the right atrium into the right ventricle. So there's a small opening. There's a small opening between the left atrium and the left ventricle as well. But you need to be able to keep fluid from backing up in the system. So if you're a firefighter and you're running long stretches of hose, you put gated Ys in. You put gated this or gated that. So that way you can close that gate to keep water from flowing in the direction you don't want it to. You want it flowing forward at all times. So we have valves. The valve between the right atrium and the right ventricle is a 3-leaf valve. Therefore, it's called the tricuspid valve. Tri for 3 leaves. On the left side, it's a 2-leaf system, and it's called the bicuspid valve. 4 or 5 years ago, I had a EMT in one of my AEMT classes, and I said, "How do you guys remember this?" And she said, "Oh, you ride a tricycle before a bicycle." I was like, "That's genius. That makes a lot of sense." So my drop of blood comes in from my vena cava. Now, the vena cava that's above the heart is called the superior vena cava because it's above, and inferior because it's below. Comes into my right atrium, comes down into my right ventricle. Now, where does the blood go from here? It goes to the lungs. Veins lead to the heart, arteries lead away from the heart. So we have to have an artery to go to the lungs. Great. My marker's dying. So we have what's called the pulmonary or pulmonic pulmonary vein. There's also a valve for this vessel, and it's right here. And this is the pulmonary valve or the pulmonic valve. You can see it written as both ways. So my drop of blood goes through my pulmonic valve, up into my pulmonary artery, out to my lungs. Now, it's got to come back to the heart. So remember, vessels that come back to the heart, that bring blood back, are called veins. So I've got 2 pair of pulmonary veins that bring blood back. 2 from the left side, 2 from the right side. So now my blood comes back through into my left atrium. It gets pumped down to my left ventricle, and then it gets pumped out through another artery. Now, this artery is the biggest artery in the body, and it's called the aorta. You have the top part, which is an arch in nature. It's called the aortic arch. Then you have the descending aorta, and that runs down to your, all the way down to your, basically your pelvis, and then it splits. And off of your aorta, all these other blood vessels, arteries run. Okay? So blood goes out, comes through. Now, arteries cannot allow gas exchange. They're thick-walled and they're muscular. So arteries have to split out into branches, and the next set of branches are called arterioles, and those arterioles then feed what we call capillary beds. The capillaries are the smallest blood vessel in our body, and they're 1 blood cell in diameter. So what that size does is it allows more surface area for that cell to contact the capillary wall to allow what we call perfusion. Now, perfusion is the exchange of nutrients in and trash out. Nutrients in are oxygen and glucose. Trash out, it depends on what kind of metabolism we're in, and we'll talk about that in a week or two. Okay? But food in, trash out, just like at the house. Food in, trash out. The funny thing is, if you're putting food in and you're not taking trash out, like at a house, and we call you a hoarder, and a human hoarder, that's kind of like your kidney and liver disease. You've got food going in, but trash isn't being removed. So we come down to our capillaries, wherever they be, my big toe, my lungs, or my brain, and we have this gas exchange. And then the blood comes back up into, ultimately, the vena cava, into our right atrium. Okay, so I've already said that the job of the atrium is to preload the ventricles. And that's actually the term, preload. The amount of blood coming into the right side of the heart that's filling that right ventricle to be moved into the lungs is called preload. I want you to think of it this way. I've got 2 water bottles. Okay? One of them is full, and one of them is half full. So if you think about our blood vessels, and we're bleeding, we're losing fluid, or we're severely dehydrated and we're losing fluid. If your tank is half full, like this water bottle, and I give it the same squeeze, you don't get a lot of return for your money. With a full one, same squeeze. Okay, that's preload. So, we can affect preload. We can give IV fluid. We can give blood products. We can change the size of the blood vessels. Preload is extremely important to this system and to what we call cardiac output. When we start talking about acute coronary syndrome and we start talking about giving nitroglycerin, preload becomes a huge part of this. Okay? Now, we have the pump. I do the same drawing when I talk about electrical. I've got my rectangle. And I've got my 4 quadrants. Remember I said that the heart sits turned a little bit and angled a little bit. This right atrium sits behind the sternum. The right atrium is where your pacemaker lies. So this is why people who get hit in the chest can sometimes have dysrhythmias, including VFib. This is why a precordial thump that you might see a doctor or a paramedic do might actually kickstart some electrical activity, because it's right here behind the sternum. Now, we have our heart's pacemaker, which is called the SA node, sinoatrial. So when you hear somebody say, oh, it's a normal sinus rhythm, that means it's coming from the SA node, the sinus node. Now, what makes it normal? Let's talk about rate. Normal is 60 to 100 beats per minute. So if it's coming from the sinus node and it's between 60 and 100, it's a normal sinus rhythm. If it's coming from the SA node and it's over 100, tachycardia. Right? So greater than 100 is tachy. So is it coming from the sinus node and it's 120? That's a sinus tachycardia. Less than 60, it's bradycardia. So if it's coming from the sinus node, it's less than 60, it's a sinus bradycardia. So this is our pacemaker. This is where all our electricity comes from, hopefully. Down here, we have what's called the AV node, atrioventricular node, and it's exactly what it is. It sits at the junction between the atrium and the ventricles. This is a pumping station for electricity. All right. Electricity for the ventricles comes through what we call intranodal pathway. So intranodal, between the 2 nodes. So it goes from the SA to the AV, goes out to the atrium so that they can fire. From here, it goes down through what's called the bundle of His. Now, the AV node will pump on its own. If it's not getting electrical stimulus from the SA node, it will kick in and fire on its own. And its normal rate is 40 to 60 a minute. Okay? Now, it's at the AV junction. So if you hear somebody saying, oh, it's a junctional rhythm, you know it's coming from the AV node. Okay? So it comes down through the bundle of His into what we call bundles. We have the left bundle and we have the right bundle. Now, I want you to think about the heart's physiology for a minute and its structure, in that the right ventricle pumps blood to the lungs. The left ventricle pumps it to my big toe and to my brain. So the left ventricle has to be stronger to do this. So the left ventricle has more muscle mass to it than the right does. We want the atrium to squeeze together to preload the ventricles. We want the ventricles in to squeeze together against each other because it gives you a better contraction, a better force of ejection to the heart, to the lungs, and to the rest of the body. So if you have a left bicep that's bigger and a right bicep that's smaller, it's going to take longer for that message to get all the way through that left bicep. So if you're trying to lift something, it's going to be kind of off kilter because it's not working together to accomplish the same goal. Same thing happens in that right ventricle and the right atrium. Because there's more muscle mass for that nervous system to innervate, big words there, the bundles are a timing system. And it's trying to provide what we call succinctum. Left and right squeeze together against. Now you'll hear the term bundle branch block. So somewheres in this, let's say left bundle, because they're fairly common, you have some damage to that bundle. So the pathway kind of fixes itself, goes out around it, and now we have a delay in that left bundle, which means that we've got the atrium together and then right left. Atrium together, right left. So it's not pumping as efficiently or as effectively as it could be. Now out at the ends of these, the actual little, where the neurons actually innervate the muscle, we have these things called the Purkinje fibers. And that's just one of those little phrases that I've always, I don't know, since the first time I heard it, it's just one of those that always struck me funny. The Purkinje fibers. Now the ventricles, if they see that the SA node and or the AV node is not firing and sending them electricity, the ventricular cells themselves can initiate their own electricity. So if it's a ventricular rhythm based out of the ventricles, the rate is 20 to 40. Okay? Another way to look at this and to think about this is the AV node is your public service of New Hampshire. It's your Eversource. It's your California Power and Lights. Wherever you get your electricity, that's the AV node. You can do everything you want, within reason, of course. You're going to have to pay for it with the AV node. So if the electrical company has an intact generating station, the lines are intact to your house, and you've paid your bill, right? You can do anything with that electricity you want. For example, I've got a welder and I've got an air compressor. I can run those. My camper's plugged in. And I've got central air. We've got a furnace. We've got 2 separate freezers and a refrigerator freezer and a dorm-sized refrigerator. Lights, TVs, all that stuff will run. You just have to pay for it. We have a storm. Wires go down. Generating station goes offline, whatever it is. Your SA node dies. There's no message getting down the intranodal pathways to the AV node. The AV node kicks in at a lower rate, providing less energy. Eversource of New Hampshire, lines go down, your generator kicks on. So like our generator is 6,500 watts. It's a great little generator. I can run my furnace during the winter and a few lights. I can run my central AC during the summer and a few lights. I'm not running my dryer off of it. I'm not running my welder off of it. Probably not going to do my air compressor either. But I can do things to stay comfortable while we wait through the emergency. So I'm not going to do everything I want, but I'm going to be able to eat and stay warm or stay cool and flush the toilet. Okay? I'm going to bring food in a comfortable environment and expel waste in a comfortable environment. Same thing with the AV node. If that goes out, your generator dies, it runs out of gas, the little bastard next door steals it, whatever it is, boom, you lose your power. Now your backup, in my case, is a 12-volt deep cell battery and a couple of lights. That's it. So with this system, your AV node, your SA node's running fine, and you want to go for a run. And you normally run 3 or 4 miles a day. That's great. You go out, you do your run, and you think, today, I feel pretty good. I'll run an extra mile. And you come back and you sit down, and you recover from it, and you're doing fine. Tomorrow you get up to go running. And instead of being at 72 beats a minute when you start, you're now at 52 beats because your SA node has died or there's a blockage, and now your AV node is kicked in at 52. And you go outside and you go to start running and you're like, whew, I'm kind of short of breath. I think I'll go inside and rest. Well, on the way by, I think I'll stop in and go to the bathroom. But that's all you're going to do. Your lights are on, you're able to eat, you're able to expel waste, and you're fairly comfortable, but you're not going to expend too much more energy. Now, AV node dies, there's a complete bundle branch block, complete block through the whole system, and this little cell down here in the left ventricle goes, whoo, hey boss, what's going on? And starts kicking in at 30 beats a minute. Now you're sitting in your chair and you think, ooh, I gotta go to the bathroom. And you stand up real quick and you're like, oh, I don't feel too good. And you sit back down and you're like, nah, I guess I'll wet myself right here. Because that's all you can do. Sitting in that chair, you're kind of breathing, you're kind of moving some food in, and you're going to expel some waste, but you're not going to expend any energy to do it. That's the electrical system in your house. That's the electrical system in our body. Now, rates are important. 60 to 100. At rest, you want 60 to 100 beats a minute. That's what we expect to see. We walk into a house and we do an assessment on a patient who's sitting in their chair. They've been sitting there for 3 hours. Are they expending energy? Not externally. So they should be on the lower half of normal, 60 to 80. But when you take their pulse at 110, 112, 114, they're expending an incredible amount of energy someplace that you can't see that's not obvious. Okay, keep that in your mind. They're at rest on the couch. They should not be tachycardic. Okay, you feel their pulse, and it's one of these guys who does the big bicycle rides, or it's the Tour de France even, much less locally, rides 100 miles a week. Their cardiovascular system aerobically is much stronger than mine is, and so they might sit in the chair not doing anything and have a pulse of 50, and that's completely normal for them. One of these guys like Greg Louganis, who used to be an Olympic swimmer, he, in the height of his physical prime, hell, he might have had a heart rate of 35 sitting in a chair. You come into my house and I'm in a rate of 35 or 40, we got some problems. I'm probably not handling it well. Gray, pale, sweaty, right? You walk in and a pulse is 40 or 50 and they're pink, warm, and dry, you can relax a little bit and start asking some questions. You walk in, I'm pale, sweaty, and diaphoretic and gray, and I look like I'm about to code, my pulse is 40, you better start working harder. Okay, so what are the rates? Where are they coming from and why? How does that system work? This is one of the things that I've had a lot of students tell me has helped them remember how this works. One of the videos we'll do also is going to go a little bit more into the electrical aspect of it, because I don't think it's right that, for example, in New Hampshire, as an EMT, you can do a 12-lead EKG, but you have no idea what you're looking at. And on the other hand, you're an AEMT, and I was taught to read cardiograms. No, you aren't. You were taught to read normal sinus rhythm, VTAC, and VFib. I don't think it's right that you have to look at these things and not know what you're looking at. So that's one of the videos that we will do. Okay. So that is the electrical system. Okay, so now we're going to talk a little bit more about the vessels. Talk about arteries. Arteries are muscular. They can expand and contract, and they can pulsate. They're strong. Structurally, they're strong. The pressure in them is also the highest because they're the closest to the outlet of the left ventricle. A vein is not muscular in nature. Now, all you got to do is look at the back of your hand, and you can see what I mean by that. right? You've got veins standing up on the back of your hand, and you can squish them easy. You can shut that blood flow back to the heart with a simple little bit of pressure. With an artery, you can't do that, right? You need a tourniquet to shut that off. Okay? So breaks in the arterial structure are far more life-threatening. Blood's under greater pressure, and it's being squeezed out of them. And it's harder to control that bleeding. Veins, typically, unless they're a huge vein, we can do direct pressure a lot of times. The other thing I want you to think about is fluid. Fluid in there. We did that with the water bottle, right? If your vessel is mostly full, it takes very little pressure to get a good squeeze out. The size of the vessels, the pressure within those vessels that the heart is pumping against is called afterload or systemic vascular resistance. So if these vessels vasodilate, you get stung by the bee, you're in septic shock, you are a spinal cord injury, and your artery and capillaries and veins, capillaries and arteries get bigger, well now, as they get bigger, you have less blood volume in them. You have less pressure for the heart to pump against, and that will also cause pressure to go down. We've already talked about rupturing of vessels. Now let's put this together as a piping system and a pump system. We've got to have fluid. In our house we have water, in our bodies we have blood. In the blood we're going to have some basic components. Red blood cells carry oxygen. Technically the hemoglobin on the red cell carries oxygen. We also will have white blood cells which fight infection. We'll have platelets which clot, and then we're going to have that medium that carries all of those particles around, and that's the plasma, the liquid part of it. I want you to think about your run. You just went for a run, or maybe like me, you think about going for a run, and you break out into a sweat. So now you got to take a shower. It's the middle of August, you step in the shower, you get shampoo in your hair, it's a nice hot shower, and your well pump dies. The pump, the heart. Something fails within that pump. What happens to the water pressure coming out of your nozzle? It drops. Now you're standing there, you get soap in your eyes, and you're crying, and it's awful. Well, if the pump in our system fails us, we don't have pressure at our brain, at our kidneys, at our liver, and it's awful, okay? Now, it's August, as I said. Your well pump's going along fine, not a problem, but we're in a drought. And those pipes that we talked about are getting lower and lower until well's dry. Our pressure's been dropping a little bit. We thought we noticed it, maybe we weren't sure, and then boom, no more fluid. Okay? Same thing happens if you lose a pipe. You know, a pipe in your basement bursts. You still got shampoo in your hair. Okay? So those are the ways that compared to our house, it's the same way our cardiovascular system works. Pipe, pump, fluids. Now I want to go into just a couple of definitions right now, so that, again, we're on the same page later. CO in this environment is cardiac output. So that's the blood that's being pumped from your heart to your brain or your big toe. There's a math equation to this. Again, I'm not the world's best at math. But what we have is cardiac output equals the heart rate times the stroke volume. Unless you're in an ICU or you're taking a patient out of an ICU like a critical care team and they've got central monitoring lines in, we're not going to be able to decide what the stroke volume is. But when you're looking at a patient and you say, man, they look shocky. Ooh, they're gray and sweaty. What you're saying is, ooh, their cardiac output sucks. Is it a heart rate problem or is it a stroke volume problem? If their heart rate is 220, the heart does not have that ability for the atrium to fill up to preload the ventricles. So your atrial kick drops. And so if less preload is reaching those ventricles, there's less blood to pump up and out. If the heart rate's too slow, we might have an appropriate stroke volume, but we're not going to have the rate to move it through the system. So roughly 5 to 8 liters per minute is normal cardiac output based on your height, size, age. Okay. If we're looking at heart rate and it's okay, I mean, it might be tachycardic at 110, 120, we kind of got to guess at this point that maybe stroke volume's low. Now, some of our patients who have CHF, for example, might be able to tell you, oh, they said something about my EF is. So ejection fraction, that's the amount of blood that's being squeezed out with each contraction. So according to the Mayo Clinic, it's a pretty big range. 60 to 100 mLs is what's in the ventricle at any given point in being ready to be squeezed out. So ejection fraction is what percentage of that gets squeezed out to your lungs and your body. 60 to 70% is what they consider to be normal, healthy. Your heart will not squeeze every last drop out, okay? There's going to be a little bit of left in there to help the next contraction, to help that next stroke volume work, okay? So some of these folks might tell you, they said my ejection, that my heart's only pumping like 30%. What that means is their ejection fraction, instead of being 65%, we'll take the average of 60 to 70, instead of 65%, it's only pumping out 30%. That is some fairly significant chronic heart failure, okay? So if they've got blood that stays backed up in the heart, they're at risk for valve damage, they're at risk for congestive heart failure. So you can ask your patients, hey, have you ever heard the term ejection fraction? What did they tell you about it? Okay, so stroke volume, heart rate equals cardiac output. When we talk about shock, we'll talk about some different things that affect all of these and how we, even as EMTs, can affect stroke volume. Okay, so that's my review of AMP at this point. Heart is the pump. Vessels are the pipes. Blood is the fluid. Okay. If you have any questions, please feel free to shoot me an email, emsabounds@gmail.com, or leave a comment down below. And I look forward to seeing you next week with kind of the first of the pathophysiology videos. Thank you.